Good evening, everyone. So today we'll be having another discussion in prosthodontics, which will basically involve the clinical evidence with how we decide the treatment planning with regards to our fixed partial dentures. So we all know the different components of a fixed partial denture, but every case is different. So we're going to approach this both from a clinical point of view and an exam point of view for you to be aware of which scenario, what type of FPD should be planned, and what are the other factors which are actually going to account for the treatment planning which is involved in the diagnosis and treatment of an FPD. So before you get down into the details, just the small basics what we all encounter during our fixed partial dentures. So we all know the different components of a fixed partial denture. That is your abutments, your retainers, your pontic, as well as your connectors, right? So as you can see over here, whenever a single tooth is missing, we basically evaluate the tooth on either side of it. And when I say either side of it, we basically want for replacing a single molar, we need to satisfy Ante's law with regards to the pericemental area. So what we basically do is we look at the condition of the second molar and the second premolar in this given scenario, and we see whether they are capable enough to withstand the load that is going to be on top of these two abutment teeth when we're giving a 3-unit long span. Now, why this is called as a 3-unit FPD is because this is one, this is the second part, and this is the third part. So, sticking to the basics still, this part which basically covers the prepared tooth. So, we prepare these teeth. As you can see, this is nicely and rounded. You see finish lines over here on both sides. So, we make it slightly more smaller just so that we can place this bridge on top of these prepared tooth. Now, the preparation also is based upon the different principles which we have discussed in the earlier classes. So I will not go into detail with that. So these two teeth, when which we're taking support from, are referred to as the abutments. Okay, the ceramic or the metal which is going to cover these prepared teeth, which is covering the abutments, is referred to as a retainer. The tooth which is going to be replaced. So, for example, here the molar is going to come and comfortably sit in this edentulous space. That is going to be referred to as the pontic, and the connection between over here, the your retainer and your pontic is going to be either rigid or non-rigid. Whenever it's a rigid-based connection, it's referred to as a rigid connector. Okay, so these are what you should basically understand with regards to a fixed partial denture. This is what it all involves, all right? The structure, the retainer, the abutment, as well as it. But how do we understand that how many teeth we have to prepare, how much tooth structure is supposed to be involved, whether it should be 3-unit or 4-unit or 5-unit? How do we base that type of treatment planning on? It is not always supposed to, like, suppose one tooth is missing, it is not always just that we take support from the tooth on either side. Some conditions may arise in which we just take the support of one tooth, or sometimes we have to take extra support or extra teeth. Some scenarios will not even be good enough in which we can give a fixed partial denture. So how do we evaluate all that is what we're going to discuss in detail right now. This is with regards to both, like I said, your clinical scenarios. You're going to be having cases like this left, right, center, as well as your exam preparations as well. Because nowadays they've gone on from asking simple questions like what is a connector, what is a pontic, to slightly more treatment based scenarios and more picture based scenarios. Okay, so ideally this is something which is important with regards to both exam based, even if you're doing your MDS based, as well as in your clinical based. This is referred to as a Pdi classification. That is the Prosthodontic Diagnostic Index. These four factors are what is going to determine how or what type of treatment plan that I should be providing for my different cases. So the first one is the location of the edentulous area, right? So you want to know where exactly that edentulous area is. Is it in the posterior? Is it in the anterior? Or there are more than one edentulous areas? All that you have to come to know. So this is the location where it is present, and extent. How long is it? Is a single tooth missing? Is it 2 or 3, or it's complete distal extension? All that you have to know. All right. So this is your first criteria. The second one is the conditions of the abutment teeth. The teeth which are going to withstand the load of the teeth what it's replacing, they also have to be strong enough. So if it's slightly less, we'll have to take more abutment teeth. When I say take more abutment teeth, we have to prepare more teeth under question. So the condition of the abutment teeth there becomes very important. So first is the location next to the edentulous area. Second is the teeth on either side of it. That is the condition of your abutment teeth. The third one is the occlusal scheme, right? It could be in the form of your molar classifications and molar relations, or how whether it's a canine guided occlusion or molar guided occlusion. Also, it also depends upon whether the patient or the individual has a deep bite, too much load on one particular area, all that. So you have to know about the occlusal scheme or scenario in the individual. And the last one is the residual ridge, because if there is a quite a wide period of edentulism, you will come to know that the ridge resorbs to quite an extent. Okay, so the residual ridge, we all know about Sievert's classification. That is another important question which has been asked in your NEET or your other MCQ based exams. So get to know the Sievert classification pretty well, because that is also involved with regards to your PDI. So you could have a question, which of the following is not a part of the PDI classification? So you have to know all these four. Also, I'm going to be classifying the class 1, 2, 3, 4 of PDA in slightly more detail. So there could be numerous questions asked upon the different PDI based scenarios. So I would want all of you to be quite aware about all these given conditions. So if you want me to repeat, I'll repeat it once again. This is for the location where the edentulous area is present and how long the edentulous area is. It could be more than one also, no problem. The second one is how the teeth on either side of the edentulous area are from which you're going to take support. Third one is how the occlusion of the patient is. And fourth one is your Sievert's classification with regards to your residual ridge. These four conditions together compensate for the PDI index, which gives us an idea on how many teeth to choose from. So coming to the first one with regards to the PDI classification, that is your class 1. So first one, like how you discussed, is based on the location, the extent of the edentulous space. So for class 1, your edentulous space is confined to a single arch, okay? Whether it's the maxillary or the mandibular, no issues. It's just to either the maxilla or the mandible. It does not have both, okay? That's what is confined to a single arch. And it does not compromise the support offered by the abutments, in which case the extent is pretty small. Okay, so like how we saw in the earlier figure, maybe just one tooth missing, like a molar, or maybe two teeth missing maximum. That is your location and extent. Ideal abutment condition in which there is no periodontal compromise of the abutment teeth, the bone loss is not there, there's no mobility in the teeth present, no pockets, no gingival inflammation, all those are not there, all right? So it is an ideal abutment condition. The teeth on either side of the edentulous space, which are going to be taken up for support, are an ideal scenario, okay? Ideal occlusion, so no deep bite, a proper angles class 1 macular occlusion is present, so no problem with the bite as well. And the residual ridge morphology of complete edentulism. By this, it means that it has adequate width and adequate height in the residual ridge. So there are no problems whatsoever. So what does a PDI class 1 basically look like? So if you can see over here, a nice equal bite when the patient is in his centric relation, a good bite which you can see, a small edentulous space which is present, confined to a single arch only. Okay, it's not in anything involving any the maxillary arch as well, only the mandibular arch, a single tooth missing. You can also evaluate the abutment teeth on either side. You do not see much gingival recession. You do not account for any kind of periodontal pockets. There is not more mobility seen. So you can easily prepare this tooth and this tooth. Now, for example, again here we have one of our molars. You can see this photo over here, one of our molars missing. Okay. So then what we do immediately is we check for the supra eruption of your opposing teeth. Okay, but here the supra eruption is pretty minimal. What actually happens is whenever there's a tooth missing, the upper tooth will always want to go into this space, what is created. So first thing what we do is we check for supra eruption, the space. Space is good, right? Occluso-gingivally, the space is good. The next we see mesiodistally. Why mesiodistally is important is because always the tooth on the distal aspect would always move towards the mesial direction. It's more common than the mesial tooth moving in distal direction, right? So we don't want them to close up the space. As you can see over here, it is almost maintained well. Okay, so the location extent is perfect. All right, the abutment teeth condition on either side is also perfect. The third one comes to the bite, which you can see is good in both centric as well as when you do eccentric movement. When I say eccentric movements, it's your lever-based movements, in which the tooth should not just slide away. All right. So this is with regards to your eccentric movement. That is perfect. Even when you do an edge to edge, right? We still see a good amount, not much forces which are going to be sitting on this teeth. You have to keep in mind that we are going to prepare this teeth and this teeth, right? So whenever there are lever forces acting on it, it will cause tipping. And I said tipping, when the patient bites over here, the bridge should not rise up. The crown should not rise up, right? It'll be a tipping motion. So you can see a very good bite. Even in eccentric movements, in protrusive movement, edge to edge movement, it is maintained well. And the fourth one, what you have to see is your residual ridge. When we say residual ridge, you're going to check the width as well as the height. And it looks fairly good for any given scenario. These four conditions is what is going to signify Pdi Classification 1. In your exams or in a clinical scenario, you could be presented with a photo like this and asked you to identify what type of classification it is. You have to keep all the four conditions under prerogative before you decide what it is. So for these conditions, all four perfect, no issues whatsoever. This is a clean example of a Pdi Classification 1. Another important thing to note in Pdi Classification 1 is I do not need to do any kind of pre-prosthetic treatment. When I say pre-prosthetic treatment, what I mean is I don't have to do any treatment to the abutment teeth. I don't have to do any ortho treatment to the abutment teeth. No periodontal treatment is required. No fillings are required. Everything is already done, right? So no pre-prosthetic or no adjuvant treatment is required in case of Pdi Classification 1. You could be asked a question on that as well. Okay, so I hope this is clear. If you have any doubts, you can stop me at any time. Just drop in a message on the chat and I will stop and be happy to explain again if you want me to. All right, so I'm going to move quickly towards Pdi Classification Number 2. Okay, so the location and extent. In the one we have in E, one of the edentulous arches. In two, we have in one or both. So even if it's present in both, it counts for a Pdi Classification 2. Okay. What you have to also understand is that the abutments are moderately compromised. So the teeth support what you're going to take on either side with regards to your Pdi are going to the abutment teeth is slightly, very moderately compromised, and some amount of adjunctive therapy is required. So, like I mentioned in the classification 1, there is no therapy which is required, but in classification 2, you require a localized adjunctive therapy. When I show you the photos, you'll understand it much better. Okay, so understand the location and extent. It could be in both the arches. It could be a slightly more long span. The abutments were not compromised. They are perfect abutments in class 1, but in class 2, they are moderately compromised. Occlusion also is moderately compromised in your Pdi class 2. And your residual ridge is again a class 2, in which there is a loss of height. And the width is still maintained, but there is a loss of height in your residual ridge. All these factors are what accounts for Pdi Classification Number 2. So how does this occur? Right? So like I mentioned to you earlier as well, what do? We first check the location of your edentulous spaces. So you can see there is one on the upper on the contralateral side. There is one on the lower as well. So both maxilla and mandible both have your edentulous spaces. All right. So another thing, what you have to understand is the slight recession which is seen with regards to your abutment here. This has undergone some amount of filling as well as treatment, but slight recession, so adjunctive therapy is recommended. You can see the bite, all right? It is slightly deep, but it's not that much that you cannot have a bridge. So the abutments, what we're going to choose are your premolar here, as you can see here, the premolar thing, but you have two molars missing. Both the first molar and the second molar are missing. So certain scenarios are going to arise. So like I told you right at the start, it is not always mathematical. Just because you have an edentulous space does not mean you will take only one tooth on either side and make a bridge. If you consider anterior slot to an extent, both your molars perisegmental area will be greater than the perisegmental area of your one premolar and your one third molar. Okay, that is going to be quite evident. So if you see that there is a lot of bone loss, there is mobility, the periodontal condition is not good, you will have to take an extra abutment. In which scenario, the first premolar will also have to be taken. So it will be 1, 2, third, fourth, the two teeth what you're replacing, and 5. So it will become a 5-unit bridge. In this scenario, they still seem good enough to stick to a 4-unit bridge only. But if you see certain more compromised conditions, you will have to involve your first premolar as well. Okay. Also, if you see, there is not much supra eruption. So the height is still somewhat maintained. Migration is not seen, which is why your abutment teeth are not compromised a lot. They're just moderately compromised. The same thing on the upper. Okay. As you can see over here in your upper teeth, small edentulous space over here, but your second molar is already crowned. Okay. So suppose this patient comes to you, or this is what's presented to you in exam. What you basically have to do is we will have to remove this crown. We'll have to remove the crown here and give a bridge from your premolar to your molar. This is a straightforward case 3-unit bridge which you're going to make over here, because the residual ridge is fine, not too much, very much. This only problem is slight loss of height. As you can see, it should have been somewhere here, but there is slight resorption of the height of the residual ridge. That is the only issue. Your abutment teeth are moderately compromised, not too much. It has present in both the edentulous space is present in both upper and lower arches. Okay, and also what you have to keep in mind is the occlusal skin. As you can see, bite is slightly heavy, not too much, and when you're doing the edge to edge of protrusive movements, there might be a slight tipping force on your bridge what you're going to fabricate. Okay, all these scenarios is what gives rise to Pdi classification number 2. Please do not confuse 1 and 2 together. These are their own thing. And for 2, adjunctive therapy in the form of scaling or oral prophylaxis is required, compulsory. Okay. And some amount of maybe GIC treatments or fillings will also be required. That is Pdi classification number 2. So we finished 1 and 2, but we did not do any kind of endodontic, orthodontic, or periodontic surgeries with regards to classification 1 and 2. That is what you have to understand. So you could get a question, which of these require a periodontal evaluation or periodontal treatment, and you will have images similar to this, and you have to take your call. Okay, so this is Pdi classification number 2. Let's move to Pdi classification 3. If you have any doubts, please, you can just type in and let me know. I will be happy to answer it. As soon as I just finish all the 4 classifications, I'll be happy to answer this. Okay, so Pdi classification 3, you can see the location and the extent of the edentulous area is substantially compromised. The abutments are again moderately compromised. Occlusion is substantially compromised, and residual ridge is a class 3. Seward's classification class 3 refers to loss of both ridge height and ridge width. Both of them are gone. However, what is different from 2 is that it is substantially compromised with regards to the location and the extent, and also the occlusion is also compromised. So let's just have a look of what Pdi Classification 3 might look like. So when such a picture stares at you, you can see that you have quite an issue to deal with regards to your PDI class 3, right? So as you can see over here, the occlusion is pretty much compromised because they're almost missing teeth almost everywhere. So if you see the maxillary arch, you have a missing teeth here, here, in here. The lower is also something similar with the distal extension presenting to you there. Now the question is, what else do I check? Now you can see over here, the upper teeth is slightly now supra erupted, so your height is reduced. So what you have to do in this scenario is do something called an intentional root canal, because you do not have space here. You will have to do anyway. This tooth is going to be a part of a bridge over here, and you can see it is drifting easily. So the strength of it is also not going to be good enough. So this tooth, I said this tooth is basically this one over here, is going to go for an intentional root canal. Now, you see the picture D, you see what is missing. The first premolar is missing, and the first molar is also missing to an extent. But what has happened is the second molar has drifted into the space of your first molar. So we do not have enough space to give a wide teeth. So we'll have to do a lot of corrections, or we'll have to give you a premolar size or shaped teeth here as well, right? Here it's still much better. We just have to prepare these two teeth and we can give a 3-unit bridge. But here what the problem is going to be that we don't have space for your first molar. Also, this tooth over here is referred to as a Pyer abutment. Okay, I think we've discussed this in the previous classes. A tooth with edentulous space on either side is referred to as a Pyer abutment. So what's going to happen is in time, this tooth, if you give a rigid connector, when I say rigid connector, it is either soldered or welded together, right? So whenever we give a rigid connector in this scenario, this tooth is going to start becoming mobile and it's going to basically fracture, which you do not want. So to avoid that, we have to give something like a non-rigid connector or something called as a tenon mortise connector for this entire bridge. Here again, what you see here is a distal extension, which we cannot treat with a conventional FPD. We have to plan either a precision, semi-precision, or a implant-based therapy. Apart from that, now if you see the occlusion, it is pretty much compromised everywhere. If you see the bite, it is compromised with regards to your anteriors as well. Your teeth as well are mobile. Also, the periodontal therapy is also required. So this scenario to treat will require a periodontal therapy, orthodontic, endodontic, all of those. That is your PDA classification number 3, in which most of the scenarios are compromised. Okay, so please do not confuse this one with your second. There is a substantial compromising with regards to your abutment teeth on either side, as well as with your residual ridge. If you can see the ridge, it is slightly resorbed with regards to both the width as well as the height, and it is not good enough to hold a bridge or a prosthodontic treatment. The last one, that is your class 4. Okay, so class 4, what you have to understand is it is severely compromised with regards to the extent and the location. Abutments are also severely compromised. The occlusion also is severely compromised, and residual ridge class 4, which means a complete loss of height as well as width, in which it becomes more like a bony spicule on the ridge area. So that has to be treated. So the 4th is the worst of the lot. The best is your first one. Second is still marginal. Third is also slightly more compromised, but 4th is the worst. Okay, so this is what a 4th might basically look like. You can see the bite is a pretty deep or heavy occlusion contact. You can see the loss of the width as well as the height completely, almost like a needle-shaped bone which is present on either side. The tooth has supra erupted. There's absolutely no space for you to give a bridge of any kind or any kind of FPD kind of treatment for precision, semi-precision, and your abutments are also compromised. So this will be regards to your classification number 4. So you could be asked a question by just in the form of an image-based scenario. You could be given photos and asked you to identify like a photo like this one or this one to identify what type of PDI classification is. You could be asked about the different conditions which are involved in your PDI classification, which is why I've been stressing so importantly that your PDI is that much more important. Even in a clinical scenario, the same conditions you're going to look at. Even in an exam point of view, you're going to look at the same conditions. So your PDA classification 4 requires orthodontic treatment, endodontic, periodontal therapy, everything. All those treatments are required. All those treatments are not required for PDI 1 and 2. 2 requires only adjunctive therapy in the form of oral prophylaxis or simple fillings. Your 3 and 4 will require slightly more bigger treatments with regards to surgeries as well as treatment planning. So this I hope is clear. You want me to repeat? I'd be happy to repeat it with regards to the 4. Any doubts, please let me know and I will happily cover it up for you. Okay. So now we know the diagnostic criteria with regards to your PDI classification. Now you know what you have to look for in a clinical setup or in an exam-based setup based on the location, the extent of the edentulous space, the amount of abutment teeth or the condition of the abutment teeth, the occlusal scheme, and the residual ridge. 4 factors always keep in mind before you're going to go for a prosthetic replacement. Now the question is, how do I go about planning the treatment in such a scenario? Okay, so now you have to basically classify them into 2 major types, that is your single tooth restorations and replacement of missing teeth. Okay, so what you have to basically decide is what material I'm going to use. Is it going to be a metal ceramic, and or all ceramic? We discussed that earlier, in which a metal or combination of metal and ceramic called as PFM, or all ceramic, that is nothing but your like your zirconia, your Emax, your lucite based ceramic, anything like that. So you have to decide what material I'm going to design. Why is it so important? Is because the amount of preparation of your abutment tooth, what you do, is going to depend on the material you choose. Okay, which is why the selection of the material is so much more important. Next comes the selection design of the restoration, as in you have to decide how many abutment teeth I'm going to take. Also, whether I'm going to use what type of connector, a rigid connector or a non-rigid connector, whether I'm going to plan a precision or a semi-precision, also the type of pontics which you're going to select, whether it has to be a sanitary pontic or a modified ridge lap pontic, what type. So all these are the designs of the restoration. That is what you select. So this is for your single tooth restoration. It's pretty straightforward, right? So you have to just decide the material and the design. If you want to replace a lot of teeth, then you have to make all these calls, right? Whether you're going to go for an RPD, you want to go for implant supported, you want to do a normal FPD, or you want to do a resin bonded tooth supported system. So this is what you have to decide with regards to your treatment planning for your single tooth restorations or for the restorations of replacing a large number of teeth. So material and design is what's called into consideration. Also, the abutment evaluation, right? So we have a crown root ratio, root configuration. If there's a crown root ratio, we all know what we're going to follow. How is the root? How is the PDL area? So all these is what you have to decide with regards to your abutment selection. So this question has been asked probably a million times with regards to what is the ideal and what is the minimum amount of crown root ratio. So 2:3, as we all know, is basically ideal, in which the root should be larger than the crown basic surface, right? So 2:3 is what is ideal. 1:1 is your bare minimum, what should be there before you decide for an FPD treatment. Also, the amount of surface area, that is your root morphology. Always you have curved roots or circular roots are always going to be much more retentive compared to your small slender roots, and a multi-rooted teeth will always give you a better retention or a better design compared to a single rooted teeth. That is just plain common sense, right? And also, if they are spread far apart, the surface area is increasing, which is why more retention is available compared to if they are close together. That is with regards to your abutment evaluation. Now, a scenario like this. Okay, So you can see what's happened here. We have a simple conventional tooth, what is missing. So what you have to understand is, how do I treat this condition? Do I go for so you can see here the second molar is slightly drifted towards the edentulous space. They have tried three different conditions in treating this. The first one, what they have done here is done a endodontic treatment or an RCT treatment for this tooth. Okay, this one. Because what happens is we prepare one side more than we prepare the other side. So if you're going to prepare one side more than the other side, what is going to happen is you're going to invariably end up into the pulp. So what we have to do is basically do an RCT treatment and then do slightly over preparation, because you have to place this tooth over here. So one option, if for a measly migrated abutment tooth, is a endodontic treatment followed by over preparation in a crown. The second one, what you can do, what you can see here, is a 3x4 crown, or what is referred to as a partial crown. Okay, 3x4 crown or partial crown. So this is another scenario which you can do. 3x4 crowns are referred to as partial veneer. The different types: 3x4, 7x8, 2x3. There are so many. So just because what happens, this will just sit and lock into this structure over here. It will not move anywhere else. But only problem is the retention is slightly compromised because it's not a full veneer crown. It is a partial veneer crown. The other option is an orthodontic movement. Okay. So what happens here is, because of ortho movement, there will be, what we do is we push the tooth slightly away from the space, and then we can still make this upright. We can make this straight like this, and then we go about preparation. But the problem with orthodontic movement of thing is that it is a delayed process. Okay. Now, because it is so delayed, we do not usually prefer this, but this is slightly more conservative come to other treatment. The other fourth option is use of something called a telescopic crown. Okay. Now, all these are only if your distal abutment has gone into the mesial space. It's drifting towards the mesial space. You have to do all this. Either go for RCT, go for a partial veneer crown, go for ortho treatment, or go for a telescopic crown. These are your options. So whenever you have asked a question, or from a clinical point of view, you want to know what should I do to a teeth or a tooth which has gone into the edentulous space, there is no space remaining. All these four are your options. You can either do RCT, you can do it into a partial veneer, you can either do a delayed orthodontic treatment, or we can do telescopic crown. What is a telescopic crown is that you do a slide preparation. There will be a crown which is placed inside this. This is very, just about 0.5 millimeters, not too thick. Okay. This will straighten the path of the tooth. On top of this, this will sit. So that is a telescopic crown, just to make the path of insertion of your bridge to become straight. This is with regards to the case scenario where there is a migration of your abutment tooth. Now coming to another scenario, another case scenario, which we saw in your class 3 and class 4 of your Pdi classification. That is your tipped or supra erupted tooth. Now, like I told you earlier, whenever there is a space present, okay, the first thing what always happens is supra eruption. Okay, so the opposing tooth will try to enter into the edentulous space. This is what first happens. The second, what happens is the mesial migration of the distal abutment tooth. It tries to move in the mesial direction and cover the edentulous space. As you can see over here, it's trying to cover the edentulous space. Here you can see the supra eruption. Here you can see the movement of the mesial movement of your terminal abutment. Third thing what happens is a very slight movement of your anterior abutment, that is a distal movement of your anterior abutment into the space. So if you are asked a question about the migration or the movement of teeth, it is in this order. Okay. Now, how do I treat this? For example, how do I treat this case? It is, if I want to give a bridge here, you will have to do an intentional root canal for this tooth and follow it up with a crown. That way, you can give the crown over here and you will have still a lot of space. Okay, so that is what is required. The migration we discussed just in the previous case, we have four in hand. You can do RCT, you can do a telescopic crown, you can do ortho, or you can do a partial venium. Okay, that is with regards to them. But how do we deal with supra erupted? Is we have to do an intentional root canal, follow it up with a crown. So intentional RCT is compulsory. Come what may, you have to do an intentional RCT and follow it up with a crown. When you give a crown, what you do is you increase the height. So you're increasing the height, and thus you have a lot of space coming between your opposing teeth. For the migrations, the tip teeth, you can do what we discussed in the previous case scenario. I hope it is clear, right? Any doubts, we just put it down in the chat and I'll be happy to answer any of them, right? Coming to the next case scenario, that is with regards to your radiographic assessment. Okay, so now you see a bone level pretty good, and if you see the crown root ratio, this is easily your ideal crown ratio of what you require of more than 2:3, right? So you have a very good crown root ratio. You see the bone, it is good, even though it's just a straight single root, good bone, it's an ideal abutment. Okay. Similarly, see the next scenario. Bone, the actual compact bone is still here. The cancellous bone is probably till here. It has still undergone some kind of filling, some kind of restoration. Your crown root ratio is probably just about enough. That is your 1:1 crown root ratio to an highest. And we can, and you see a nice pocket which is being formed over there, nice space between the two teeth. This is a moderately compromised scenario. Okay, moderately compromised scenario. This is ideal scenario. Okay, this is what you're going to look for in case of your abutment teeth. But this is a severely compromised scenario in which the bone is getting resorbed completely. There is almost just one portion of this and probably around 2:3 ratio. The ratio is not good enough. So this will be slightly grade 1 mobility. So what do I do for this case is if you see that FPD, a bridge is the only option, then you have to involve both these teeth as an abutment to replace a single tooth here followed by a terminal abutment, right? So you have to increase the abutments whenever you see there are not enough good condition of your abutment teeth. So this is where a radiographic assessment becomes so important. So in your exams, you could be just given an X-ray or an OPG like this and asked you what tooth you will select as your abutments, whether this is good enough, whether that is whether we should go ahead with increasing the abutments, all those options. Please take a wise choice about it because you should know how much bone is required. Stick to the same crown root ratio to help you out. Also see the presence of any other pathology. And this basically is the enlargement of your PDL space. So you know there is some amount of mobility and that will not be a good abutment. Okay, so this is what you go about doing a radiographic assessment for your abutment teeth. Now, this is one very dodgy topic. Okay, why do I say it's a dodgy topic? Is your canine. The replacement of canine is very, very difficult from both a theoretical perspective as well as a exam-based perspective. Okay, why? Your canine is the strongest anterior abutment. Okay, there's nothing more stronger than your canine. So its replacement makes it more issue, because when you replace your canine, you will be taking the support of your lateral incisor on one side and your first premolar on the other side. So this will become a 3-unit bridge. So these are your two abutments. Your pontic will be in your canine, and this is how you're going to fabricate it. But the problem is this: your lateral incisor is your weakest abutment in the entire mouth, and your first premolar is the weakest posterior abutment, the second most weakest abutment in your mouth. So taking support from these two becomes, that is because you're taking to replace a very strong abutment, you're taking the support of two weak abutments. Okay. So ideally, when we replace a canine, what we do is we call into perspective the patient's bite or occlusion. We try to prevent any kind of canine guided occlusion, because what's going to happen is the patient is going to keep biting on this area, it will tip, and after some time, this will either dislodge or fracture the abutment teeth on either side. Okay, so this is why it has to be kept in mind whenever we are replacing a canine. Don't only just understand that we're going to replace it with this, with your first premolar and your lateral incisor. The occlusion also is kept in mind. If your lateral incisors are not good enough, you have to take the support of your central incisor as well. Okay, but once you involve the central incisor, there will be a difference between the central incisor on one side and central incisor on the other side, right? Because this is going to be a crown, this will not be a crown. Then what individuals do is, just to replace the canine, they involve the central incisor as well. So just to, instead of doing a 3-unit, it becomes a 5-unit bridge, which is not economically good, and neither ends against the principles of your tooth preparation, that is your preservation of tooth structure. So always keep in mind, the canine replacement is very difficult to understand and to do, but it varies on a case to case basis. If your bite is not that strong, it's still good enough, everything is fine, your lateral and your premolar should do the job for you. If your lateral and your premolar are not good enough, they will not be able to retain your canine like this, in which case you have to increase your abutments. You can also involve your second premolar if you want. If you're worried about aesthetics becoming hampered when you're using the central incisor, you can use your second premolar as well. Okay, I hope canine replacement as a treatment scenario is understandable to all of you. Slightly difficult, but like I said, on a case per case basis regarding to the condition of your abutment teeth and the occlusal scheme. Now, the question is, where can I give a cantilever scenario? Like we just discussed replacement of canine. Can I take the support of a premolar and replace a canine? The answer is a no. Can I take the support of a lateral incisor and replace a canine? The answer is a no. Okay. The only way we can give a cantilever is by taking the support of a canine. A canine can be taken as a support and replaced either the lateral incisor on one side, or if the bite is not too compromised, you can also replace your first premolar, because the canine is strong and it's surrounded by weak abutments like your lateral incisor and your first premolar on either side. Right? So that is with regards to your cantilever scenario. So only the canine can give you a cantilever scenario. Canine can replace both the lateral incisor and a first premolar, in which you do not have to. Now what happens is, just to replace a lateral incisor, we will have to, if you're going to give a 3-unit bridge, we'll have to replace both the central incisor and the canine, right? Just to replace it. Right? If you're going to spoil the central incisor, the aesthetics are going to get, because the crown, however well you do it, is going to stand out from the central incisor other side. What we do is, we have to prepare this one, prepare this one, prepare this one, just to replace a lateral incisor, right? Not called for. Just prepare the canine, and that is good enough, and give a cantilever on the lateral incisor. That's it. The same thing holds good for a first premolar. If both your If your premolar, again, if your bite is not that bad, you can use a canine and replace your second premolar as well. Do not ever do something like this. So what has happened over here is we have taken the support of the premolars on either side and given a cantilever to the molar. Okay, you have to understand when the patient bites like this, it will lift on the other side. Same way, if the patient bites on here, it will lift on the other side, like a proper seesaw motion, because here there is not much occlusal forces. But here, the molar is your primary tooth where occlusal forces are going to land on. Okay, as well also your premolar. So what is going to happen is there going to be a nice tipping motion, and it should. So whenever you're asked a question about your cantilever, or you're asked in a clinical setup where you can give a cantilever, where you should not, your canine is the only way where you can give it to replace your lateral and your first premolar. Nowhere else can you ever give a cantilever based scenario. Okay, so this is regards to your cantilever treatment scenario. So example, something like this, right? We have a canine over here, we have a canine over here. This is a case which is done marvelously well. We haven't involved the central incisors, right? So we do not involve the central incisors to in any given level, and we can easily either mask it with an orthodontic treatment, or we do not. We just prepare the canine as an abutment and give your. We do intentional root canal obviously for this case, and then we give a cantilever on your lateral. So this case basically required an orthodontic correction followed by a prosthodontic treatment. And this is something which I want to deal with regards to case scenario. This can never be done. You can never bond a 3 units. This is 1, this is 2, this is 3, right? They're all joined together, 3-unit bridge. You can never join a tooth with an implant, come what may. Why? Because a tooth has something called as the PDL, that is your periodontal ligament. So when forces act on the tooth or on the crown, it will transfer it to the PDL. As you know, PDL is a shock absorber. It's a stress reliever. It takes a bit of the stress and distributes it all across the bone. But the implant does not have a PDL, right? So what the implant does is when stresses act on a tooth, when you're joining it together, this is not in the individual scenario, only if you're joining it together. When the patient bites here, it will transfer the forces to this tooth. The implant will concentrate all the forces on itself, and they will start becoming bone loss all around the implant. After just 1.5 years, this implant will fail. So never ever bond a tooth to an implant. The tooth should be separate and implant should be separate. You can do something like this. Implant, 3-unit bridge, and you can join them together. This is perfectly fitting well. But you can join a tooth to a tooth, you can join an implant to an implant, but never do an implant to a tooth, right? Because you have to know in which scenario you're going to involve a tooth and which scenario you're going to go for an implant. So please never ever bond this together. They will definitely fail. If you're asked a question like this, the main reason is because the implant does not have a PDL in it. Okay, so please be aware of this with regards to the implant bridge scenario. Also scenarios like this in which now you see this tooth, what's wrong with it? The furcation is completely involved, right? The furcation is completely involved. Can I use this as an abutment tooth? Yes, if you can do an endodontic treatment process and there is not much mobility, you can still do it. Though there is slight mesial migration, we can still prepare. When you prepare it, what you have to do is you have to follow the gingival anatomy, in which you will give a finish line on the furcation area itself. If you do not close this area, food is going to enter and this tooth is going to fail along with your bridge in 6 months' time. Okay, so you take this as an abutment, take this as an abutment, do RCT. Okay, follow it up with preparation. If the tooth, there is no other periodontal pathology, like there's no mobility, there is no pockets present, then you can definitely use this as an abutment tooth, but give the finish line as close to the gingival architecture as possible. Then you can give a nice 3-unit bridge all across, right? This case, you have to give a non-rigid connector because this is a pyre abutment. So the technician isn't going to give it for you. If you give a rigid connector, so the abutments over here are 1, 2, and 3. But if you are going to give a rigid connector, this will fail within 2 to 3 years because all the stresses will be concentrated on the pyre abutment. So you have to give a tenon mortis connector or a non-rigid connector always whenever you have a pyre abutment. So this is with regards to this scenario. Okay. Also, this is what it basically looks like. This is your pyre abutment, right? So you took one abutment here, two abutment here, and so is a third abutment. This just goes and locks into it, like how your door bolt is there at home, right? So if you when you open and close, that way you should. That's how exactly how. So you can see this is a key. This is the lock on your doors. This just goes and locks into. This is called as a male or a female connector, tenon mortis connector, or there are so many other names. This is referred to as your cross pin and wing connector. This is slightly outdated right now, okay, in which we place this and we put a hook through it. So this is what we usually do it in all our labs and all from a clinical point of view as well. So tenon mortis is usually the preferred choice of treatment. This is with regards to a case what we did earlier. So you can see a pyre abutment here, a pyre abutment over here. These are normal conventional cases. This is just one abutment here on either side. This is conventional, but for a pyre abutment, we do something like this, right? So this is if it's just normal bridge. We just go about doing 3-unit bridges on either side. But if you have something like this, in which you have pyre abutment on either side or even on one side, we do a non-rigid connector and we cement it. So cementation, everything, the preparation of the tooth, everything is the same. The lab does this and gives it for you. You just have to cement it, cement the anterior portion first and then the posterior portion. Okay. So this is with regards to your non-rigid connector and your pyre abutments, how to deal with. This is with regards to your resin bonded bridges. I will not go too much deep into this. Is your Maryland and your Rochette bridges, right? Where we treat them with chemical agents, or we have certain wings or perforations by your lost salt technique or Virginia technique, and this just goes and bonds with it. This is a very minimal preparation or conservative management of replacement of missing tooth. Okay. Another one, what we can do is something called a FRC. FRC is nothing but a fiber reinforced bridge. This can be used as a conventional treatment until a definitive treatment becomes possible. As in, you can see the anterior tooth is missing over here. You are planning for an implant, but you want the bone to become slightly more better. So what we do is with composite, we bond the lingual portion of the fiber on the either side of your abutment. So we are not preparing this tooth, we are not preparing this tooth. We're just attaching a fiber band from one side to the other, just like Spider-Man, how it moves from one building to the other. So this is actually like a Spider-Man thing. So this is from one side to the other, right? And we bond it with composite. We stick it with composite. Okay. We then build the entire tooth from composite, or we can also use acrylic. Okay. So acrylic will be basically in the form of the tooth, what all of you select. The what we use like Premadent or Acryrock, what you use for your dentures. We can also acrylic tooth we can use, shape it similar to the other tooth on either side and bond it with composite. So this is also an option. But FRC is more of a provisional treatment. It is not a definitive treatment. It's just for maximum 6 months to 1 year until the condition of other abutment teeth or the bone improves. Okay, I hope that is clear. With regards to your fiber reinforced bridge or treatment, you could be asked questions about these as well. What is a better or what a conservative management? FRC is the best because we are not preparing even 0.1 millimeter of the tooth. So that is why FRC is a very good option. So precision, semi-precision is a slightly complicated topic. I don't want to go too much in detail with this. Just understand this. Precision is prefabricated. Okay, so we have these components which are there, similar to what's there in your doorknobs and your window knobs to lock in. Precisions allow movement of 0.0001. So this means they do not allow any kind of movement. Okay, it gets locked and it's tight. Semi-precision is a custom made. When I say custom made, it is made according to the patient's requirements. Okay, and these allow slight movement of close to 0.2 to 0.3 millimeters. Okay, so there is movement in semi-precision. There's no movement in precision. This is prefabricated. This is lab. So these are different ways on how it work. It could be either intracoronal or it could be extracoronal. Okay, when I say intracoronal, we embed them within the tooth itself. When I say extracoronal, they come out of the tooth which is crowned. That is all you have to understand. Please don't go too much in detail. Precision is a very confusing and complicated topic. Just understand that precision does not allow much movement because they are already machined parts, whereas semi-precision is a custom or laboratory made, and hence it allows some form of movement. Okay, and this is another treatment scenario. As you can see, the patient's complete residual ridge is lost. So there is no width or height. Both of them are gone. So how do we treat such a, so you can see in this computer generated model, what we see, the complete ridge or height is gone. So how do we treat this patient? We give something called an Andrews bridge. Okay. So what is an Andrews bridge? Is basically we have a combination of an FPD plus an RPD. So to go forward, making an Andrews bridge, we prepare the tooth on either side, right? So you can see over here, we prepare these abutment teeth, okay? And we hang this bar from the abutment teeth. So this bar is hanging with two ball-shaped attachments on either side, okay? To this attachment, as you can see over here, we already done this. To this attachment, we join an RPD. This is an RPD trial. It's made up in wax. So you see the bridge on either side. That's a bridge and an acrylic RPD on the anterior aspect. So we can do a combination of FPD plus an RPD. It's referred to as an Andrews bridge in patients in which both the facial-lingual height and width of the residual ridge is completely lost. Okay, this is referred to as a Andrews bridge, is a different form of treatment altogether. Just keep this in mind in the form of a scenario-based question. So you should not be dumbfounded when something like this appears as an image-based question or in your clinical setting. And last but not the least, the implants. Let's not go too detailed into this. Is a simple thing. A single tooth, we replace it with a single implant and the tooth. More than one teeth are missing, we give something called an implant bridge. Like I told you earlier, you cannot join a tooth to an implant. You can join two implants together. Follow it up with two completely edentulous mouth, two implants. We give a ball attachment and we finish it off. And for the final one, we give a bar-shaped attachment again. So there are different modalities or scenarios in implants that we take care of. Okay, so this is with regards to the different treatment scenarios which are also possible in implants. The possibilities are endless with regards to both FPD and implant treatment, and it varies from a case-to-case basis. So you should have an idea of what goes for what patient, keeping your Pdi classification in mind. Once your Pdi is clear, then your treatment modality will also become clear based upon the setting what you have. If any doubt, please let me know.